The first case is from Mr. O'Brien's team, and Mr. Daniel Murray, one of our neurosurgical SPRs, is going to present it, and it's called a case of severe craniofacial trauma. So go ahead.
Thanks, Prof. Can you see my screen?
Yes.
Perfect. Okay. Great. Thanks, Prof. My name's Dan. I'm one of the neurosurgical trainees in Beaumont, and I'm presenting our case of severe craniofacial trauma on behalf of Mr. David O'Brien's service. So we'll get straight into the case. We have a 31-year-old right-hand dominant gentleman with no real relevant past medical or surgical history. He was intermittently taking SSRIs for mild depression, but otherwise very fit and healthy guy. And he sustained a very significant craniofacial trauma while doing some woodwork at home. He was using a lathe, which is a spin, and a wooden bowl came off it at an estimated 40 miles an hour and made contact right in the mid-face. So the emergency services were contacted by the family. They heard the commotion, and initially his GCS at the scene was reported to be 6 out of 15, which was E1, V1 and M4. His pupils were dilated and unequal, but they were sluggishly reactive at the scene, and a helicopter transport was arranged to get him directly to Beaumont Hospital. So when he arrived to Beaumont, his GCS was 8 out of 15. He was not opening his eyes, and he wasn't making any noises, but he was obeying commands. So in terms of the primary survey, his airway was at risk, both because he had a low neurological status, but also he had some tongue swelling, extensive facial injuries, and there was bleeding in the back of his throat. In terms of his breathing, I mean, his saturations were okay and his respiratory rate was okay, but nonetheless, his airway was at risk. From a circulatory point of view, his blood pressure was okay, a little bit high systolic, and his heart rate was fine. Neurologically, there was no focal weakness on exam. He was moving all 4 limbs spontaneously, but again, he did these extensive soft tissue facial injuries with profuse bleeding from the nose down into the mouth, and a left facial laceration up towards the forehead. He did have raccoon eyes, suggestive of basic skull fracture, as well as tongue swelling, as I said. So the decision was made to intubate him. He was sedated and ventilated and brought for imaging. So this is a CT scan. The left slide, you can see the brain windows, and on the right, you can see the bone windows. So on the brain windows, there's a couple of very important things to note. I'll slow it down and just show you what exactly I'm talking about. But basically what we can see are kind of polycompartmental hemorrhagic contusions, worst here at the front, in the frontal lobes, just here in this area. You can also see a lot of pneumocephalus, so these black spots in the subarachnoid space here, and then down in the fourth ventricle and in the basal cisterns, which means there's air getting into the intracranial compartment. He's also got shallow subdural hematomas, worse on the right, along here and here as well.
Dan, if you can point at things, it'd be very helpful.
Sure, of course.
Slow it down and point, yeah.
Of course, yeah. So down low, we've got some subdural hematoma along the tentorium here. We've got these black spots, which are evidence of pneumocephalus. You can see here and here. And up higher, this is the real area of concern here. These are the frontal contusions, so they're hemorrhagic contusions. As we look over to the brain windows, it's quite obvious. You can see these displaced, comminuted and depressed frontal bone fractures, which on the left side actually crosses across the sagittal sinus, or at least the sagittal suture, which concerns us that there might be an underlying sinus injury. But these frontal bone fractures all along here were of concern to us. We obviously proceeded to get a CT of the facial bones because there was such extensive facial injuries, and just as it happens, his C-spine and T-spine imaging was negative for any pathology. So we were really dealing with a focused craniofacial injury. So as we look at the facial bone imaging, there's so many different things to discuss here, and I don't want to spend too much time on it, but basically we've got depressed comminuted frontal bone fractures, as you saw in the last scan, but they involve both the inner and outer tables. There's several comminuted and displaced fractures of the bilateral lacrimal bones, the nasal bones, the cribriform plate, the sphenoid and maxillary sinuses, and both of the ethmoids. The greater and lesser wings of the sphenoid bones were fractured on both sides, and there was a basisphenoid fracture involving the right carotid canal. I'll just show you what exactly we're talking about here. So this is a fracture that's crossing the carotid canal on the right, and then we've got all of these extensive mid-face fractures as well. Another really important thing to note is the fractures around the orbit, here and here. So there were osseous fragments in the right orbit and the left orbit from the fractures. And on the right-hand side, it's actually compressing the superior and medial recti muscles. And on the left, the superior rectus is also affected. So, I mean, there really aren't many bones here that haven't been affected by this trauma. You can see on the coronal imaging as well, the same thing. I'll just go through it slowly, but you can see that the extent of these fractures there. I'll spare you the sagittal imaging. So I won't read out a radiology report, but that's what we were dealing with. So the receiving team, when the patient arrived, was made up of a consultant neurosurgeon, Mr. O'Brien. We also had a consultant neurointensivist in the ICU waiting for the patient, a consultant neuroanesthetist in theatre with Mr. O'Brien, and a consultant maxillofacial surgeon who were examining the scans as they came through. We also had a neuro-ophthalmologist on the line at the time. So there was a decision to be made at this point about what we were going to do. Are we going to proceed directly to a decompressive craniectomy, which is going to be difficult in the context of somebody who's got such bad frontal fractures? And so the decision at the time as a group was made to insert an intracranial pressure monitor. And that would give us an indication of whether or not a decompressive craniectomy was indeed indicated, but also would help us with management if he were not to need further surgery when he got back to the ICU. So he, as I said, intubated and ventilated, sedated, paralysed with retrocurium. He was given tetanus toxoid and pneumococcal vaccine due to the fractures. 200 millilitres of frank blood was aspirated from the stomach when an orogastric tube was inserted. And so the intracranial pressure monitor was put in, all of the facial wounds were cleaned and sutured up, and we managed him as per TBI protocol in the intensive care unit because the intracranial pressure was actually okay when the monitor went in. So an ICP monitor is something that we use a lot of the time in these kinds of cases where we put a little probe through a little drill. We put a little hole in the bone, pop the pressure monitor through, and it gives us a second-to-second reading of the intracranial pressure. Another important part of that is the waveform, which you can see along here, and these waveforms are actually really important. So the first, the P1 here is the arterial pulsation. And then the second little notch is the tidal wave, which represents the brain compliance. And the third is the dicrotic wave, which is where the aortic valve is closing. And this is similar, I suppose, to an ECG in the sense that if you have a good waveform, that's reassuring, and it means you're in the right place and you're getting a good reading, and you can rely on the intracranial pressure readings. But obviously, if there's abnormalities, it's a different story. So in the intensive care unit, the patient was managed per the TBI protocol. So you're monitoring them by the minute and trying to optimize all of these different parameters. So the mean arterial pressure is really important. So the patient will have an arterial line. You want to look at the cerebral perfusion pressure. That's the net pressure gradient that drives oxygen delivery to the cerebral tissue. So obviously what you want to do is prevent secondary brain ischemia. So that's a really important part of management. So the CPP is the difference between the mean arterial pressure and the intracranial pressure, and maintaining an appropriate CPP is critical in managing these patients. And the normal CPP lies between about 60 and 80 millimeters of mercury. So this can only be calculated, obviously, when you have a mean arterial pressure and an intracranial pressure, and they must be measured simultaneously, and that's obviously by invasive means through the insertion of an ICP monitor and an arterial line. And maintaining adequate CPP in clinical situations of intracranial pathology with or without deranged ICP will decrease that risk of ischemic brain injury. We're also looking at the vital signs, the heart rate, the blood pressure, the saturations, the patient's temperature. The partial pressure of carbon dioxide is obviously very important as well, because we typically want to keep the PCO2 sort of low, between 4.5 and 5. If you hyperventilate the patient, you'll get arterial vasoconstriction, which brings down the cerebral blood flow and the cerebral blood volume, and thus decreases the ICP. So we keep a close eye on that as well. We're also looking at the bloods, we're looking at the sodium, we're looking at the hemoglobin, and pupillary assessment is important, because if a patient is sedated, you don't really have a neurological exam, so your only real reliable sign is the pupils. Now, in this particular case, unfortunately, the patient had fixed dilated pupils bilaterally. Now, in a lot of cases, our assumption is that the reason that their pupils aren't working and they're enlarged is because they've herniated. In this particular case, it was a little bit more complex in that the patient had bilateral orbital fractures. His optic foramina were also narrowed as well, so he was likely to develop a traumatic optic neuropathy. And his ICP was in normal range and never breached 20 or 25, which is the highest level where we need to get involved. And it had a good waveform. So we were sort of reassured by the ICP. And in that context, the pupillary dysfunction, it wasn't quite clear what it was due to. Was it due to the orbital fractures or direct trauma, third nerve palsies, or from uncal herniation? Although things were going quite well in that sense, it was noted that the patient had CSF rhinorrhea. He had CSF pouring from his nose. And so the same day, that evening, the decision was made to insert a lumbar drain. The risk, obviously, if somebody's leaking CSF is that they'll develop a meningitis. And the decision was made to go ahead and put in a lumbar drain. Now, the problem with putting in a lumbar drain in this particular context, again, is that you run the risk of creating a negative pressure gradient and thus sucking air into the head and creating a problem via pneumocephalus. Thankfully, the CSF drained off nicely. We didn't run into any problems with pneumocephalus, and the CSF leak dried up after a few days. So during the inpatient stay, the GCS unfortunately remained very low. We did full active management throughout, optimizing all those parameters I've already spoken about. And by day 4, we had completely weaned off the sedation. The lumbar drain was then taken out. Repeat imaging was performed, which was, relatively reassuring in that it certainly hadn't worsened. But unfortunately, the patient's GCS didn't really improve. There were times where it was reported that he was flexing. But generally speaking, his GCS was at about 3 out of 15, and he had fixed dilated pupils. So we need to start having conversations at this point about what's the best thing to do going forward. There were regular conversations with the patients next to kin, and ultimately the decision had to be made after a week or two of a persistently low GCS with fixed dilated pupils about what we should do next. And the decision ultimately was made between the options of extubating the patient and seeing what happened. Ultimately, that could result in the patient either expiring or needing to be reintubated, or moving to a tracheostomy. So the decision was made again as a group between the family, the consultant neurosurgeon, and the neurointensive team to insert a tracheostomy and give the patient a chance. In order to prognosticate, an MRI brain was performed on the 12th day. And I'll just go through some of the important findings on this. So I couldn't include all of the MRI sequences, but we have a T2 scan on the left and a diffusion scan, a T2 scan on the right and a diffusion scan on the left, a B1000. And some of the important things on this, I'll just show you very quickly. So if we look at the left image here, there's this abnormality in the pons. It's also susceptibility artifact on another sequence, but basically this is either an evidence of diffuse axonal injury or a contusion, which can be, if it's diffuse axonal injury, that's a really poor prognostic sign. We can also see diffusion restriction here in the caudate nucleus and to a lesser extent in the lentiform nucleus, and that again can be suggestive of either hypoxic ischemic encephalopathy or indeed diffuse axonal injury. There's also restricted diffusion around the frontal lobes there as well. You can see the multifocal hemorrhagic contusions are still quite evident here frontally and to a lesser extent in the parietal lobe and occipital lobe. And there's these scattered microhemorrhages at the grey-white interface, which again are suggestive of diffuse axonal injury, these little dots. So overall, the MRI findings are really quite concerning. And at this point, objectively, we have a patient with a low GCS, a patient with fixed dilated pupils, and a patient with MRI findings that are suggestive of pathologies that most people will not recover from and make any meaningful recovery from. So as I said, the tracheostomy was performed just after the MRI. He was discharged to the ward on day 19. The decision was made at that point that whatever happened, he wouldn't be for readmission to the intensive care unit. And then, miracle of miracles, one day we get a call from the nurse on the ward to say the patient is obeying commands. And from then, things start to tumble in the right direction. He had a gastrostomy inserted and he was decannulated about a week or two later. And by week 6 or 7, his GCS was 15 out of 15 reliably. He then began to walk and mobilizing on the ward and started engaging with the rehabilitation team. When he was up and about, of course, he then developed a delayed CSF leak for which he did ultimately need further surgery. So the surgical repair of that consisted of a bifrontal craniotomy via a bicoronal incision, which is essentially where you go from ear to ear and it gives you really good access to the frontal bones and the anterior cranial fossa. So with Mr. O'Brien and Mr. Pádraig Ó Ceallaigh, our Max Fac surgeon, they did a craniotomy. They took off that fractured bone that you saw earlier and repaired it. They also found 2 dural defects which were repaired, and ultimately the CSF leak thankfully dried up. This post-op CT is the only one we have that shows the work of the Max Fac's team. He had a CT angiogram, which I've put the bone windows in of, and he had that because ophthalmology were concerned with persistent chemosis and all of these orbital and ocular problems, that there may be a CC fistula has developed. Thankfully it hadn't, but we do have these images to show you just at the top here where those frontal bone fractures were. Excuse me, you can see how the bone has been repaired and put back into its proper place. So very impressive. From an ophthalmological point of view, these are the visual field tests, and the left eye is on the left of the screen and the right on the right. And what we can see here is that there's central visual loss in both eyes. Obviously much worse on the left. This blue area is an area in the patient's central vision that he can't actually see anything. So he's got central visual loss bilaterally, worse on the right hand side. The visual fields, these areas here, are pretty much full on the left hand side, but quite diminished on the right, likely due to the cranial nerve problems and the orbital fractures that affected the musculature of the orbit. He also had a macular rupture on the right and choroidal rupture, and he had a ptosis from a third nerve palsy. His Ishihara score was 0 out of 15, so he didn't have any color vision. And I think the ophthalmologists were quite convinced that he had a cranial nerve 3 and 6 palsy on the right hand side. His visual acuity at the last test was 3 out of 60 on the right and 4 out of 60 on the left, which for all intents and purposes is almost functional blindness, but he manages to get around quite well, thankfully. We have to pay homage to the teams who got him from the end of his acute point to his discharge, and the neurorehabilitation team in Beaumont really do deserve the plaudits here. So from dietetics and neuropsychology, OT, physio and SLT, they saw the patient day in, day out, and put management plans in place that got him to the point where thankfully he was able to be discharged to the National Rehab Hospital. So after 146 days, he ended up in the NRH, GCS 15 out of 15, no limb deficits, and independent with his activities of daily living. So obviously he's got a lot of ongoing issues, but he's making fantastic progress with that rehabilitation. So the learning points in this case, obviously, we're dealing with major craniofacial injuries, and the importance of having multidisciplinary teams here on site can't be understated. We had a consultant neurosurgeon, consultant anaesthetist, neuroanaesthetist, and a consultant maxillofacial surgeon there on the day when the patient arrived, making decisions in real time. Another thing that was important was the orbital and the globe injuries, as well as the neurological injuries and the difficulty with pupil assessment. Really, it wasn't clear if the patient was going to survive, never mind make any sort of reasonable recovery. So it is a fantastic story, but something that none of us really, to be honest, expected. And the last thing that we wanted to note is just the importance of that CSF leak in the first place. I suppose when Mr. O'Brien was making his decision and those fractures were there was a known CSF leak, it was likely that had he not had a route for CSF to escape, that he may have had really high intracranial pressure. But the fact that he could decompress himself by virtue of those fractures and the CSF leaking was an important thing to happen. Thank you all very much for your time. I hope you enjoyed it, and be happy to take any questions.
Thank you very much, Dan. Really fantastic presentation. I thought you presented it very clearly and made the points very well. Really, really good case to start with. And I'll just, nobody's posted questions, which I'd love you guys to send some questions in, but I just want to go through some of the points about the case itself, because it kind of demonstrates the teamwork that's involved to get a good outcome. And some of the key issues that you raised with a person with a low GCS, I think you mentioned, with the blood in the back of the throat, with the swollen tongue. And I liked the very much emphasis on the airway management at the very, very start. That initial management is what makes a huge difference in terms of, as you know, as you mentioned, the preventing the secondary brain injuries. So the low GCS, intubate, GCS 8 or less, intubate, airway obstruction with the swollen tongue, blood in the back of the throat, intubate, intubate, intubate. So that was very well made. I thought you made some references to to things that were kind of neurosurgical, and I just thought it's worth kind of making some points about them. You showed the fractures very well, which were going across two types of sinuses: the air sinuses, the frontal sinuses, which you then mentioned resulted in the CSF leak that in the end needed a repair. And then the superior sagittal sinus, which is a venous sinus, but it wasn't actually injured, Dan, am I right?
That's correct, yeah. It was just a concern based on the imaging, yeah.
Yeah, it's a concern I suppose we have sometimes when a patient, say with a subdural hematoma, is referred and a fracture is going through the superior sagittal sinus. It can be a little more difficult in terms of surgically controlling the bleeding and things like that if we take the bone off. And then you also mentioned the fracture through the carotid canal. And interestingly, I think before the summer, we had some presentations on traumatic arterial injuries. And of course, you did a CTA here, which did not show any carotid injury. So again, the vascular injuries were ruled out. I thought you demonstrated a teamwork very, very well. And the kind of unexpected kind of outcome that you mentioned is something we sometimes see, isn't it? And it's why we are sometimes reluctant to pull out when somebody is in the neuro ICU and they're not doing well, and you're just wondering, should I do a trachea, should I not? It's not an easy decision. And for the reasons that you just demonstrated, is that it's not always easy to predict. Even with an MRI scan, which showed a contusion in the brainstem, the patient still ended up actually making a good recovery given the extent of injuries. It's interesting you showed the diffusion restriction in the caudate heads, and you kind of just wonder whether some of the degree of his inability to follow commands, for example, would have been due to kind of the motor fibers just not transmitting the signal from his motor cortex down to his limbs. So the low GCS may have been misleading in that situation. I have one person saying the decision made not to take the patient again back to ICU needs to be addressed. And yes, that's the sort of decision, I suppose. Dan, do you want to comment on that? I suppose it's something we review regularly, isn't it?
It is indeed. Actually, it might be Mr. O'Brien himself might be better placed, because he was part of the team that made the decision at the time, if he'd like to speak on it.
Yeah. Yeah, thank you, Dan. That was a great presentation. And the reason we do this is all the indicators for this patient were very negative. GCS very low at the start, although he was obeying commands. He was mainly in ICU after we've turned off sedation, GCS of 3, pupils fixed and dilated. He had hits on his MRI scan. And we have a chat with the family, and this is not infrequent, where we've got a patient with a very poor prognosis, and we say to the family, or we discuss with the family, we don't tell them, it's an agreement that if a patient deteriorates and they have a low GCS, we have that discussion about our ceiling of care. Now that didn't apply in this specific case because he miraculously was improved. The patient with GCS of 3 on the wall, self-validating, that you need to have a chat with patients, with the family to decide, well, if this patient arrests, what should we do? Should we intubate and ventilate? And that's not uncommon. That did not apply to this patient.
Yeah, David, you're breaking up a little bit, but I think the point's made that it's not a decision that's made and not reviewed again. There are a couple of hands up. Joseph Mbatia.
Yeah, thank you so much for the nice presentation. I'm Joseph Sembata from Uganda. I'm a first-year resident neurosurgery. I have just a few questions to like to ask as a resident. Maybe I can be answered in that order. One is I've never seen such a presentation of a patient who reaches a Gascoma scale of 3 with all the expertise I've seen, all the senior consultants around, reaches the Gascoma scale of 3, then discharged when it's 15 out of 15. This is actually, I've never seen it personally. So I would love to inquire what could have happened and what could have gone wrong, all right, between the time of discharge from ICU to the ward, because we are seeing from the ICU, as if it was squarely between 3 and 6. Then from on the ward, the presenter said that the nurse informed them that the patient is obeying commands. Could there be an explanation for this? Because we have seen throughout that the patient really wasn't doing well, but suddenly we are seeing an improvement. Is there an explanation maybe from the neurosurgeons who are here who can help me really understand this clearly?
Yeah.
Then the other question is,
yeah. So
can I first finish?
Sure. Okay, go for it. Be quick, because
okay,
I have people with their hands up.
The other question is, what was the rationale for the first decision of a decompressive craniectomy in such a patient? Because I'm not seeing it anywhere personally. The rationale of a decompressive craniectomy, the first decision which was taken in such a patient with such findings on the CT. Thank you so much.
Okay, no problem. I suppose to answer your second question, decompressive craniectomy wasn't performed in this patient. An ICP monitor was inserted. In terms of the recovery, we do see it actually. If you work in neurosurgery for 10, 20 years, you actually do see patients that present with a GCS of 3, and initially it takes them a very, very long time, but eventually do make a good recovery. So it's something that we see not just in head injuries, but subarachnoid hemorrhage and other conditions as well. So it's not that, it depends what level of brain injury at the end of the day they have. Of course, it's a poor prognostic factor, but it's not concrete. It's not set in stone that people with GCS of 3 do not recover. So with time they do. We're a bit short of time, so I'm going to take a few more comments and questions. Ger Curley, I think you had your hand up there. Am I right?
Yeah, just really briefly, most congratulations to Dan and Mr. O'Brien on a fantastic presentation and a really fantastic outcome. And neuroprognostication, as we all know, is really very difficult. And in ICU, after global injuries, after cardiac arrest, we have really good discriminators for when patients are going to have a bad injury, when they have a global ischemic insult. But when you have heterogeneity after traumatic brain injury, it's just really difficult. And I think this case underlies that, and this case was managed really well, where tracheostomy was inserted, and the patient was weaned for mechanical ventilation, was discharged to the ward, and the patient made a recovery. So I suppose it's just to congratulate you on that, and that just to really briefly, with such severe basic skull fractures and frontal bone fractures, it would have been likely that he had a lot of cranial nerve injuries. Wouldn't I be right in saying that that he, more so than just the optic nerve, there probably were more cranial nerves involved in injury? Would I be right in saying that, Dan or Mr. O'Brien?
Yeah, so 2, 3, and 6 were definitively affected, but thankfully he got away with just them.
Great.
Yeah, I suppose sometimes with the base of skull fractures we can have further cranial nerve injuries. That's great, Ger. Good comment. There is a couple of other things. David Menzies has asked any thoughts on earlier intubation, such as pre-hospital in these cases. I think that is a good point, and it's probably not for me as a neurosurgeon really to comment on. And David, if you want to make a comment, I think I agree with it, and I don't think anybody would disagree with that. In terms of the earlier that intubation is done, the better. And if it's done on the scene, now I'm not familiar really as to the difficulties of establishing something like that. Also, another question is, did the patient have, in terms of frontal sinus injuries, a role for cranialization? Do you have any comment on that, Dan? Cranialization of the frontal sinuses?
Yeah, they were cranialized intra-op during the repair. Yeah, absolutely.
Yeah, and that's basically you cranialize it, remove the posterior wall of the frontal sinus, and remove all of the mucosa to make sure that later on there isn't any mucocele formation. Okay, I think for the sake of time, we really have to move on with the second presentation. Thanks very much, Dan. Excellent presentation and an excellent case with a nice outcome at the end of it. So we have another presentation from Mr. John Caird, consultant neurosurgeon in Beaumont and Temple Street Children's Hospital, titled "A Growing Skull Fracture, a Gift that Keeps Giving." John, are you there?
I'll go ahead. So this is a pediatric case initially, and really it demonstrates how a relatively innocuous head injury can manifest in something that requires repeated neurosurgical interventions and long-term neurosurgical follow-up. So this case, she's a 5-month-old girl who had fallen from her mother's arms and hit her head. So she would originally presented back in 1988, was admitted locally to Limerick, where they did a skull x-ray, and that showed a right parietal skull fracture. And as for majority of these, were just kept as an inpatient, had neurological observations, and once she was well, was discharged home, which is what happened here. She then represented about a week later. The parents then noticed that she was developing this boggy swelling that was gradually enlarging at the site of her injury, and at which point they represented back to the emergency department in Limerick and underwent further investigation. So this really is a representative lateral skull x-ray. Obviously hers are filmed in an archive somewhere. So I just lost the slide there. Yeah, on the left, you can see a lucency, which represents her skull fracture, and then on the right-hand side, after a short interval, when she represented, would have been something like this, where the skull fracture had expanded. And the next slide, please. Again, representative CT. So on the left, showing bony windows, where there's an arrow just pointing at a defect at the inner table. And spreading a hyperdensity within the cloak area, but on this CT actually there's an intact outer table. And on the MRI on the right hand side, again with arrow, is shows where the dural defect is, with a small area of brain parenchyma just herniating into the defect, with the surrounding CSF, which you can see is similar density to the CSF within the ventricles. So if we move on to the next slide, please. So essentially, she admitted into Beaumont, underwent a right parietal craniectomy and had repair of that defect. And at the time, they used a xenograft, which would have been bovine pericardium. Post-operatively, then she developed a subgaleal CSF collection, or pseudomeningocele, and they ended up inserting a subgaleal shunt going from the swelling into her peritoneum. Again, uneventful recovery, discharged home a week later. Next slide, please. So she represented again with another swelling at the same site almost a year later. She had a CT at the time, which showed recurrence of the CSF collection, and then underwent revision of the proximal end of her shunt. The swelling then became slack, resolved, and was subsequently discharged home and seen in clinic 2 months later, where this had recurred once again and had a skull x-ray which showed that this skull defect had persisted. Next slide, please. So in the end, they had to do a split calvarial graft. So this was taken from the contralateral side. So took some bone from the contralateral side to repair the defect on her right side. As with some of these traumas, they can develop a post-traumatic hydrocephalus. So she did require a left frontal VP shunt, and removal of the cystoperitoneal shunt. However, she did get a couple of years out of this, but this graft did eventually become infected and failed, and was removed, and she was left with bilateral defects now. She was referred up to Belfast, where they had developed the titanium cranioplasties and had bilateral cranioplasties there. And she did well after this, went home, uneventful follow-up, and remained well for 21 years. Then in January of this year, she noticed that the titanium plate was in fact protruding from the right-hand side. Was seen in clinic, was planned for an elective admission for removal of this. However, a week or so later, presented into Galway with nausea, fevers, raised CRP, and was commenced on empiric antibiotics, vancomycin and meropenem for CNS cover. She was transferred down to Beaumont in April 22 and had a removal of that right titanium plate. However, because of her multiple surgeries, plastics were involved early and were there for the surgery, and they turned a local flap and also put a split skin graft over the defect as well. These are the x-rays from her shunt series actually, pre-operatively, which shows the titanium plates. So in the lateral, you can see the titanium plate, and then on the AP, you can see nicely that she has the bilateral plates either side, and the screws which secure them in place. Next slide. If we just play the video, please. So this is a CT of bony windows, and yeah, so it's scrolling up. So we're going from bottom to top, and you can see the shunt catheter on the left, and then coming into play are the titanium plates, and just on the right, the skin becomes thinned out just anteriorly and superiorly. And that's where the site of the defect was and her leak. And the next slide, please. So this should be the post-operative CT. It essentially just shows that she had the titanium plate removed from the right-hand side, but it also shows the calcification of the underlying either galea or dura that has ossified with time as well underneath the titanium plate. And the next slide. So this was her post-operative wound. So obviously she had extensive old wounds from her multiple surgeries from before, and then had her flap raised and a titanium plate removed. And if we go on to the next photo, and then anteriorly you can see where her skin graft was, and the extent of her wounds. And if
you can see the image Mal very kindly rotates. So we were short of there was skin gap here. scalp defect here where the plate had extruded, and obviously the scalp doesn't allow for stretching, or even with a bit of undermining, it wouldn't pull across. So Nadim made an incision right away all along here onto the left side, bearing in mind there's a cranioplasty on that side as well. And then rotated the scalp posteriorly to cover that small defect here, and then had to cover the corresponding defect anteriorly with a split skin graft.
And the next slide, please. And this is the patient holding her titanium plate, which she brought home with her. And the next slide. So this is on her follow-up in clinic. So you can see how it's healed up nicely after the plastics intervention. And next slide. So essentially, skull fractures, they're partial or complete break in the skull bone, and by virtue of being fractured, it indicates that a substantial enough force has been applied and increased the likelihood of injury to the intracranial contents. And the next slide. These are the common fractures that would be seen in pediatrics. So the top left would be the linear fracture, which is what she would have had, and on the right, the prescal fracture, which you see a lot in pediatrics. They also call them ping pong fractures, where it literally looks like a ping pong has been bounced off the skull. And these remodel with time as the brain gets bigger, as it develops. It literally just remodels the bone above it, and it rarely need intervention. Bottom left being the diastatic fractures across sutures and basilar fracture. And the next slide. So growing skull fractures, there's about 1% of skull fractures in childhood occur after head trauma in an early age group, so usually within the first 3 years of life, and exceedingly rare than beyond 8 years. The term was coined as early as the 50s. It's also known as other terms, where earlier, and even going back to the 30s, would have been known as a leptomeningeal cyst, which a lot of people would use again today. The next slide, please. The features for a growing skull fracture. So again, early childhood, there is a dural tear at the time of fracture, as well as brain injury underneath the fracture. And then obviously the fracture enlarges as it grows to form a cranial defect. And the next slide. Pathophysiology. So again, it's due to the dural defect, so the laceration in the dura. And as I was saying earlier, the brain volume increases rapidly in the younger age as they grow older. And under that, you have the pulsatile force of the brain as that expands, causing the fracture to enlarge. And then this, together with adhesions from the arachnoid, creates kind of a ball valve mechanism, trapping CSF within the cyst. And then the tissue essentially just gets in the way of the fracture and the two sides of the bone healing, preventing osteoblasts from migrating into the site, inhibiting healing. And you can also get resorption of the adjacent bone, and this is due to the continuous pressure coming from that kind of herniating defect. And then next slide, please. It's just a graphic representation of what I was saying. So in the top left, you have your fresh fracture, you have your dural defect, and then you have CSF within the arachnoid pulsating out, coming into the defect, and also rolling bone side by side, where eventually on the lower image, you can see the cyst has formed, the arachnoid adhesions either side, trapping CSF within it as it expands under the pericranium. And the next slide, please. So it's a quick case, but in summary, the skull fracture is a relatively innocuous injury in childhood and is rarely followed up. Careful follow-up, though, is required, including monitoring of head circumference to allow early identification of a growing skull fracture. But even with early intervention, it can require multiple interventions, as was the case in this case, due to the sequelae of that underlying pathology of the growing skull fracture and the traumatic hydrocephalus. And this was a gift that keeps giving. Thank you.
Thanks very much, Owen. That's a nice case and well presented. I suppose it highlights the kind of some of the long-term problems that a head injury can cause, which maybe sometimes we don't address quite as much. Can I ask you, Don? I mean, is there a way of is there anything to predict that a fracture is going to become a growing fracture, and is there a way we could prevent it, or?
Not really. I mean, they're very much in the mind. We only in our pediatric practice, we might see one a year at most. Out of all the dozens of linear and displaced fractures that we see, I suppose if you see intracranial air on the initial CT, or something that suggests that there's been a dural breach, one might be a little more. Your antenna might be up a little more, but it's a rarity. And but we do follow these patients up. We have an advanced nurse practitioner now who follows all our kids who are admitted with a skull fracture in clinic about 6 weeks later to make sure there's no buggy swelling or anything of that nature. And I think, as Owen alluded to, the pathogenesis here is that you have a dural tear, you develop a leptomeningeal cyst. It's really driven by raised intracranial pressure from post-traumatic hydrocephalus, which pushes the arachnoid out into the crevice between the two bony edges and preventing the bone knitting and pushing the healing edges apart and giving you that term growing fracture. And so in this case, it was obviously she had a most unfortunate clinical course with having a split calvarial graft that both of them became infected and had to be removed, and then essentially the whole back of her head was a bony defect. And then it was interesting that she went to Belfast for her titanium cranioplasties, because these were developed by a neurosurgeon in the height of the Troubles. Derek Gordon was now deceased. His son is a plastic surgeon in Dublin, but he developed with the at the Royal Victoria Hospital in Belfast, along with the George Blair from the Royal Victoria Hospital Dental School. He was an expert in dental prosthetics, and they developed the titanium cranioplasty and wrote it up in the British Medical Journal in 1974. And it was the sort of de rigueur treatment for blast and high velocity bullet injuries in the Northern Ireland conflict for decades. And became used around the world. So they developed now we found that subsequent titanium, although it's a very inert process, inert substance, it does eventually come through the skin, but it can be decades later, as in this case. So and I have no doubt that at some stage I'll be seeing her back to take out the other plate. But I'm not quite sure what we're going to do then. But hopefully I'll be retired by then. But it does eventually. It's a great solution, but it isn't a perfect solution, and it does come through the scalp eventually. And the scalp, as you know, is unforgiving. If it's eroded, you can't get more scalp. You've got to rotate a flap.
Yeah, that's very interesting. I didn't know the history behind the titanium cranioplasties, and it's kind of been superseded now by the PEEK and the plastic ones. And
it has. Yeah, I think we've enough experience of it now to know that most of these eventually have to be removed, and the hydroxy apatite, like custom bone, the sort of ceramic type. With the personalized, customized implants are far superior, really.
Yeah, and just with the titanium that came out, you didn't replace it with anything. There had been.
I didn't. Now this is about her 9th operation, and that particular wound had been opened multiple times and had shunts put in under it. So the wound was heavily compromised, and I felt that any attempt to replace any type of cranioplasty would likely fail. And so she's managing with that. She does have some dizziness when she stands up quickly, but she's managing. She's fine. And I think she doesn't have CSF dripping at the top of her head now, and she doesn't have to wear a dressing on her head. So it's fully healed. I suppose at some point the other one might give trouble, but we'll let sleeping dogs lie for now, I think, and see how she gets on.
Yeah, a very good, really good case. And can I just ask you? You said one thing that took me by. You said every skull fracture in a child is followed up.
That is referred to neurosurgery is followed up by an advanced nurse practitioner. She has a special clinic that she sees all these kids in for usually one visit post-op, and we never hear from them again then. But if they're and most of them are admitted for observation.
For observation,
and much as this child was 6 years ago.
And a skull fracture in a child, is it similar to in an adult? Would you CT scan all of them, or do you just admit them for observation if they're well?
Most of them will have a CT on presentation if there's symptoms. Yeah.
Yeah, that's what I thought. I have one person's hand up, Madana. Do you have a question to ask?
Moshin, this is Kumar Ekanak, maxillary surgeon,
Hi.
maxillofacial surgeon.
Welcome.
Thank you. And it's a very good presentation by John as well. I'm just about these cranioplasty, the titanium plates, we had the same problem. And in the past, you might remember those days, 20 years ago when we were training, we used this bone source hydroxyapatite, the solution, and then it sets on the brain. And again, it caused the same problem, So I think
yes,
nowadays,
there were the acrylic plates that you sort of molded. They had a sort of in situ chemical reaction. You mix two things together, it became hot, and you molded it into the
Yes.
The acrylic plates. Again, they have fallen out of favor in the new custom-made patient-specific implants have overtaken.
Exactly.
Thank you for your question.
Thank you, John.
Thanks very much, guys. Okay, I think we'll probably wrap it up there. Thanks for the presenters. Both cases were really interesting, and both were very well and clearly presented. And we'll continue with the neurotrauma webinars. As I say, if you have cases you'd like to present or you want to discuss with me, email me at mjavatpur@rcsi.ie. And if you have comments or suggestions, let me know. And otherwise, we'll see you first Wednesday in October, which Rebecca reminded me which it is, and I have lost it now. But
5th of October.
5th of October, everybody. See you then. Thanks very much.
Do you want to put your email address in the chat just so people have it
if
they want to contact you?
There now. Hopefully, I won't regret this for the rest of my life, but I am going to do it anyway. And thanks for our international attendees. I hadn't realized that we have international attendees. So the neurosurgical SPR from trainee from Uganda who asked a question, I was gobsmacked actually to realize that there is international attendees. So thanks very much for attending. Good luck, everybody. See you in a month. Thanks, Rebecca.
Thanks, Mosen.
Thank you, both.